Good morning, everyone. My name is Camilo Gonzalez Velasquez, co-host of the Thyroid by MD's webinar series. I would like to welcome all of you today to today's session. We are delighted to have you all here as we gather for an enlightening lecture by a distinguished expert in the field. Before we begin, let me introduce our esteemed presenter for today, Dr. Louise Davies. She is a renowned authority in the field of otolaryngology and head and neck surgery. She's a professor in the Giesel School of Medicine at Dartmouth and is a member of the Dartmouth Institute of Health Policy and Clinical Practice. Additionally, she serves as a senior faculty at the VA Outcomes Group at the Veterans Affairs Medical Center in White River Junction in Vermont, where she also holds a position of the Chair of Otolaryngology and Head and Neck Surgery. Dr. Davies has dedicated her clinical practice to the management of thyroid and parathyroid diseases, cancers of the head and neck, and laryngology. Her expertise in these areas has earned her recognition and respect among her peers and patients alike. Beyond her clinical work, Dr. Davies is a methodological research expert in cancer epidemiology and screening. She has deep understanding of mixed methods research approaches, in particular in the context of patient experience, healthcare improvement, and clinical trial implementation. Today, we have the privilege of having Dr. Louise Davies deliver a lecture on the topic of overdetection in thyroid cancer in women. And before we jump into the presentation, I do want to encourage all of the listeners to share any questions through our Q&A function. I will try to get to them at the end of the hour. So with no further ado, Dr. Davies, the mic's all yours.
Thank you. I had to find my controls there. Thank you for having me. It's really a pleasure to be here, and it's always nice to be invited to get to talk about a topic like this to such a broad audience. What I'd like to do today is to talk about thyroid cancer and the issues we face in deciding how to approach the workup and thyroid nodules and identified cancers, especially as it relates to how we manage the disease in women. And I'll be using two illustrative cases that I think capture the two ends of the spectrum that we need to be concerned about. Much of what I'm going to present today is from my own research, and so I want to give credit to my collaborators across the globe, Katie Bell and Louise Kanamori in Australia, Suhail Doi, who's in Qatar, David Francis at the University of Wisconsin, and Diana Lamb and Anna Saka in Vancouver and Toronto, and Carissa Leclerc, who is now in California and was a medical student with me through 2021. So first, let's consider the two very different cases. So the first patient that we're going to have in our minds as we go through these cases today is Miss L. She's a 49-year-old veteran who in 2016 presented with neck discomfort in the setting of a prior neck injury from a car accident. Actually, one of her main concerns was having swollen glands all the time. And she had swallowing discomfort that sometimes even happened at night. She had an ultrasound ordered by her primary care provider as part of her workup. Her history was relevant for obesity, exercise-induced asthma, sleep apnea, hypothyroidism. She was already on thyroid medication. She had a history of bipolar disorder, no childhood exposure to radiation, strong family history of cancer, but not thyroid cancer. And on physical exam, her nodule was not palpable. She did have notable muscular tension in her neck. She had normal vocal cord function and some postcricoid edema of the larynx, which can sometimes suggest some swelling and irritation from reflux that's undertreated. So here's a picture of what her thyroid nodule looked like at the time. It was 7 by 6 by 5 millimeters. And it in 2016 and moving forward was followed annually with serial ultrasounds, actually. So I meet her in 2020 because she moves to the area and establishes care with a new team and has a new ultrasound where the thyroid nodule is actually described as bulging the thyroid. And it's still less than a centimeter in size. A biopsy is done, and this is a Bethesda 3 AUS. A ThyroSeq test was performed, and this was read as a high probability of malignancy. So she was referred to me for surgery. She was actually a quite reasonable candidate for active surveillance, which is what I encouraged her to do, but actually she preferred a total thyroidectomy. So let's just keep her case in mind, and let me talk to you about this second case from my practice. This is Miss H. She's a 67-year-old veteran. She'd also been referred for a thyroid nodule. She also had a complaint of swallowing problems. She also had other upper aerodigestive tract issues of nasal congestion. And she had this incidentally detected thyroid nodule when they were working up her swallowing problems. She described the onset of those about 12 months ago, since her husband had died. She pointed actually to the sternal notch area when she described her swallowing issues. And she actually thought liquids were worse than solids. She also described this tightness in her neck that the other patient had. She had her thyroid nodule found on MRI. And when I pointed out where her thyroid nodule was for her, she said, oh yeah, actually my neck is often tender right there. She had a similar physical profile in terms of her history. She had obesity also. She had sleep apnea, spinal stenosis, chronic pain, hypertension, coronary artery disease with a history of MI, diabetes with neuropathy, CKD stage 3A. No exposure to childhood radiation, strong family history of cancer. And on exam, she was a very different patient for me to encounter as a first visit. She had a left thyroid nodule that was palpable. The area was tender. The nodule felt quite hard. It actually felt contiguous with an enlarged lymph node nearby, probably just because it wasn't very mobile, because on imaging, you'll see it doesn't quite look like that. Her bedside ultrasound showed us suspicious lymph nodes that were rounded and had irregular borders. And the nodule I rated as a TI-RADS 5. She had normal vocal cord function. So here's just a visualization of her thyroid nodule and what we could see on imaging of the adenopathy. She had a Bethesda 4, her ThyroSeq was also positive, high likelihood of malignancy. So both patients, very different presentations, both ThyroSeq positive. She had a lymph node biopsy that showed she had metastatic disease. So she's not a candidate for active surveillance, right? She needs an operation. So we actually did her operation. We started with the left hemithyroidectomy and the left central and lateral neck dissection with a plan to do a complete thyroidectomy, but her cancer actually was invading her cricopharyngeus muscle. So for people who are on the call, who are not surgeons, who maybe don't think about this every day, I've circled there on this nice netter picture where the cricothyroid muscle is and the cricopharyngeus muscle. And you can see how closely and intimately related that is to the nerve. And her tumor had invaded that area. And while we were able to resect some of the muscle and peel the nerve away with the traction and just general handling of the nerve, we had a loss of signal intraoperatively. And the current standard of care in that case, if you have the ability to do so, is to stop, see if the nerve recovers, and give it time to do so, which is what we did. So it's interesting to think about, and we'll talk about this across the cases here. You know, what is the prognosis for a person like this? Does the fact that she's a woman actually make a difference? Should we say, well, she's a woman, and even though her thyroid cancer invaded the cricopharyngeus, thyroid cancer is not usually as aggressive in women. So let's go on to talk about these things. What I'd like us to come away from the talk today with is to revise these two common wisdoms that I think sometimes get misinterpreted. The first is this idea that women get thyroid cancer more often than men. And these statements aren't wrong per se. Well, actually, the second one is thyroid cancer is more aggressive in men than women. But things aren't actually that simple. And when you look at the actual epidemiologic data, we'll see that it's not quite that way. And these are things that I thought about for a long time, and we worked on trying to figure out how we could answer these questions in a way that would be intuitive and helpful and help us with the way that we manage and approach patients. So to come at this, we first asked ourselves, well, we know that thyroid cancer is sometimes found at autopsy in people known to have died of other causes without their cancer coming to attention. So how do diagnosis rates, the rates at which we find the cancer, compare to the underlying prevalence rates at autopsy by sex. We'll talk about things related to that, and I'll walk you through the findings from the paper we published. But let me give you a little bit of background first, make sure we're all on the same page. So when you look at what's happening in thyroid cancer today, just to start us off, I show this picture not because I don't think people are unaware of which are the most common cancers, but to show really just how much papillary thyroid cancer dominates the thyroid cancer landscape. And it accounts for 90% of cases in recent years. And thyroid cancer has always been a disease more of women than men, but I think we have to, there's an interesting story to this that I'll talk about later about how these proportions have changed. Now, when we think about how men and women have an incidence of thyroid cancer that differs, there's been a lot of basic science research to look into potential biological reasons for why this may be. I'm not going to focus on these today, but I just want to draw your attention to these as areas of ongoing research because we haven't really answered the questions about whether there's a biological difference that is as meaningful and as large as what we see when we look at the clinical differences. So there are two excellent reviews that summarize the thinking in this area. The first is by Suto, which came out in 2021, and the other was led by Shobab with Wartovsky as the senior author. And some of the key findings are that related to hormones, estrogen alpha seems to promote the growth of papillary thyroid cancer, while actually estrogen beta type inhibits its development, and estradiol, at least in vitro, promotes tumor proliferation and migration adhesion. The underlying molecular mechanisms for how these happen is not at this time well understood, but it's an area of research for us to understand how biologically cancers might be different between men and women. The other area to think about is what's happening literally at the genetic level. And in the TCGA analysis, thyroid cancer ended up being grouped in the strong sex effect group, meaning that there were 78 genes that showed sex-biased signatures. 40 of the 78 were located on the sex chromosomes. The TCGA was actually not really designed to study sex, and the role of menopause was not considered in these analyses, but it's intriguing and it's an area of research that is ongoing. And the last thing I just want to mention is the concept of epigenetics issues and potential differences in immune surveillance. So I'm just going to leave that so that we can move on. So these days, 43% of all the thyroid cancers that are detected are localized, meaning they're contained within the thyroid gland, and they're 2 centimeters or less, and they're papillary type thyroid cancers. The annual mortality rate of this group, meaning the number of people in the United States who die having been diagnosed with this kind of a cancer, is very small. It's 1.4 per 10 million. The annual mortality rate due to any thyroid cancer is 50 per 10 million people. And just to put this in proportion, the total US cancer mortality is 15,000 per 10 million in the United States. So thyroid cancer deaths account for only a very small number of the deaths from cancer overall in the United States. With such a low mortality, how do we actually usually treat people? Before we talk about that, I think it might be helpful to understand how we used to think about papillary thyroid cancer, because historically we treated it with oftentimes total thyroidectomy, and that reflected different ways that we thought about this cancer. And if you look back, if some of you are old enough on this call to have been around in the 1990s, papillary thyroid cancer actually only made up about 80% of diagnosed cases, and there were many other kinds, and the sizes of the cancers were also different. Now, when looking at the 2010s, the proportion of cancers that are papillary has risen to 90%. And of course, we have a much larger number of people who are diagnosed overall. This represents a 300% increase. And interestingly, half of the increase was over just 7 years, 2002 to 2009. And 87% of that increase was in thyroid cancers that measured less than 2 centimeters. Mortality during this time did not improve, so we weren't picking up cancers and helping people prevent death due to that cause. And what's interesting is that the absolute increase in thyroid cancer incidence in those years has been 4 times greater in women than in men. This is relevant because all of this detection of this subclinical disease led to change in guidelines. There was a broad recognition that we were finding cancers that likely weren't clinically active. And so then the ATA guidelines suggested, among others, the NCCN and various radiology groups also came out with guidelines about biopsying, but they suggested that we should be decreasing the proportion of people who are getting total thyroidectomy because their cancers probably didn't need it based on the extremely high survival rates and the extremely low mortality rates that I just shared with you. So we actually did a study. Lisa Cawley was the first author. This was under the auspices of the American Head and Neck Society. And what the data show over here is that as of 2019, this is from an institution in the United States and one in Canada, looking at by-year rates of thyroidectomy. So among people who would have been eligible for hemithyroidectomy, the proportion that actually did receive that or received a total thyroidectomy, about 40% of people by 2019 who were eligible for hemithyroidectomy were still having a total thyroidectomy. So that's a lot of women undergoing a total thyroidectomy who probably didn't need to have their entire thyroid removed. So this idea that women get thyroid cancer more often than men is the one that we'd really like to take on first. And then we'll talk next about thyroid cancer and whether it is more aggressive in men than women, and whether that second case that I mentioned with that woman with the metastatic lymph nodes, whether her prognosis actually is any better than the man's. So when we decided we wanted to look at this, we actually went back to this work by our colleagues who I mentioned at the beginning who collaborated with us on this study, to a really landmark study that they published in 2016 looking at the autopsy data. And what they showed is through a meta-analysis of 35 studies that reported the autopsy prevalence of thyroid cancer, meaning people had died of something else, but were found to have a thyroid cancer at the time of their death, never knowing that they had it and without a history of thyroid disease while they were alive. There was a broad range from as low as 0.6% to 35% of people having one. And it actually depended on how closely you looked at the gland, how much you found. And they found that if you looked at just part of the gland, the part that looked abnormal, then the rate was about 4% of people who died of other causes had a thyroid cancer. Generally speaking, it was usually papillary, on rare occasions, sometimes submedullary or follicular. If you looked at the whole gland and you just serially sectioned it, the rate was about 11%. So what we can discern from this is that the closer you look, the more you find. The other thing that I thought was helpful and interesting about this meta-analysis is when you look at this graph over on the right, it has time across the bottom on the x-axis and the prevalence on the y-axis. And what we can see is that over time, from studies that were before 1970 to those that were after 1990, there has not been an underlying increase in the prevalence of thyroid cancer in the population. So there's not a change over time in the rate at which we would find papillary thyroid cancer in people who had died of other causes. So we decided that we wanted to pair up with this team to look at whether there was a difference by sex. You know, is there more underlying thyroid cancer in women than in men? So we repeated the meta-analysis, we updated it, we looked for any new studies that might be out, and we restricted our analysis actually to studies that reported prevalence and actually also looked at the whole thyroid gland, because we thought that that way there would be less bias about men versus women. They had to report prevalence of papillary histology and then prevalence by gender. And what we found is that in the 12 studies that had 2,300 people in them, there actually was no difference in the reservoir of latent papillary thyroid cancer between men and women. So in women, the rate was 14%, the men was 11%, but if you look at the confidence intervals, they're really overlapping. So there's not a clinically meaningful difference in the underlying prevalence of subclinical thyroid cancer in men compared to women. So this idea that women get thyroid cancer more often than men is true, right? Like we do find more thyroid cancer cases in women than men, but it's important to know that the underlying subclinical prevalence is actually the same. One of the reasons we think this might be happening, you know, I mentioned the biological reasons that are under study at the beginning of the talk. And I don't want to discount those, but I suspect that they're not quite as large as some of these other things might be. So first of all, it is actually true that women do have more thyroid nodules than men, but women utilize more healthcare than men, and that's been well established. And this persists even if you control for things like reproductive health visits. But this just generates more opportunities to find small asymptomatic cancers. And if you think back to that first case I presented, this was a woman who presented with what sounds like musculoskeletal neck pain after a car accident with visibly tight muscles, but she left with a referral for a thyroid ultrasound, which ended up being part of her workup. That was not necessarily inappropriate. We don't know what the setting was, but she went and sought out care for that muscular tightness. And so she ended up with a thyroid ultrasound. Men tend to be less likely to seek healthcare for their symptoms, generally speaking. There's also something about what we do as clinicians. And it turns out that women are actually more likely to be referred for thyroid ultrasound than men. And we tend to get referred for more vague symptoms, things like fatigue, menstrual disturbance. This has been shown both in larger studies and in a nice study that came out by Dr. Haymart, where she looked back in the Medicare population at the first imaging that had been used and on which the thyroid nodule was identified, and it was thyroid ultrasound. When we want to understand how these come to attention and who's undergoing surgery, it's important to understand that about 70% of patients who are having thyroidectomy for cancer these days, in a study that we published also under the auspices of the American Head and Neck Society, but this one led by Mirabel Sagisevi, 70% of them had no symptoms referable to their thyroid at the time that the cancer was found. We used a special classification system that we developed and validated previously and then updated for this study. And we had 18 institutions participate in this. Here's how they usually come to attention. Radiologic serendipity, which is when you get a test, an imaging test for a completely different reason, and it shows a thyroid nodule. Lung cancer screening, MRI for neck pain, CT scans of the chest and neck for other purposes are common reasons. Screening physical exams, even non-palpable nodules, because sometimes structures in the neck can seem asymmetric, or certain things are felt and thought to be potentially nodules that turn out not to be or are something else. Other endocrine conditions sometimes can lead to finding these thyroid nodules. And then this issue of what we call a diagnostic cascade. For those of you who are surgeons, we may not think about this very often, but when people come to you with generalized symptoms such as fatigue, my colleagues who are internal medicine physicians say, the textbooks might say you should do tests in a stepwise fashion. First, you should get a couple of labs and then see what happens, and then you do another set of tests. But in reality, for efficiency, they will often order multiple tests at once. So for someone with fatigue, they might order a TSH, they'll order a bunch of other labs, and then they might actually send a person for a thyroid ultrasound, which actually is not indicated for that. But maybe they thought they felt something on physical exam, and so they go ahead and send them. So these are the ways that we uncover these cancers that are asymptomatic, but are there. So let's take that common wisdom of women getting thyroid cancer more often than men, and let's just make it a little bit more nuanced. It's important to remember that the underlying subclinical prevalence is the same, but we do have many more opportunities to find it in women than we do in men. So let's go on to the second one, this idea that thyroid cancer is more aggressive in men than women. So for this data, we turned to NCI data. SEER, for those of you who might not be familiar with it, the Surveillance, Epidemiology, and End Results program is run by the National Cancer Institute. It collects and quality checks data from high quality registries across the United States that are representative of the United States in terms of population. The oldest group is called SEER 9. It's the original 9 registries that made up the cohort. These days, actually, we do get data on incidents from all 50 states. But the nice thing about this SEER 9 group is that we have data on them going all the way back to 1973. So that's why you'll sometimes see people saying they use SEER 9 or 13. The 13 has data from 1990 and onward, for example. This is the United States' best source for cancer rates and data that's population-based. So we understand and know that and can trust that it represents what's truly happening in the United States. So women have experienced a much larger rise in thyroid cancer incidence than men since the 70s. Men have also experienced a large rise, but because men started out at so much smaller absolute rates, it just doesn't look quite as impressive in the men, right? So in women, when you look back to about 1990, since then, there's been a 389% increase in papillary thyroid cancer per year. The rates went from 4.6 per 100,000 to 17 per 100,000. Men also experienced a huge increase, right? 295% increase, but they started at such a low rate, 2.2 per 100,000. Their absolute increase was only 4.3 cases, so they went up to 6.5 per 100,000. What gets really interesting is when you look at what happens when you look at like who's getting which kinds of cancers. So I want to walk you through this figure, because if you understand this, then you really understand exactly what's happening. So on the left, on the y-axis, we have the ratio of women to men. So when you're down at the level 1 there, you're at a 1-to-1 ratio of women to men in terms of incidence rates. And as you get up to the 4 and 5, it means the ratio of women to men is like 4-to-1 and 5-to-1. And when you look at the ratio of new thyroid cancer cases annually in women compared to men, women are diagnosed with papillary thyroid cancers less than 2 centimeters, more than 4 times as often as men. As you come down to all other papillary, so meaning the larger cancers, follicular and Hürthle cell cancers, which are more rare and more aggressive, and medullary and anaplastic, you can see that the ratio between men and women comes closer and closer to 1. So aggressive cancers occur not exactly equally, but definitely more equally in men and women. The other thing to know is that thyroid cancer actually is, mortality is similar by sex. So when you look at the ratio between women and men for all thyroid cancer types, the ratio is 1.02 to 1, so nearly 1 to 1. And for papillary thyroid cancer, it's 0.96 to 1, so also nearly a 1 to 1 ratio. And just as a reminder, the prevalence of the autopsy rate of subclinical thyroid cancer, that ratio is essentially 1 to 1. Remember, that was the data that I showed, the rate of subclinical thyroid cancer at autopsy in women is 14%, and in men it's 11%, with overlapping confidence intervals. I think an important thing to here to remember is that case fatality is not the same as mortality. And when we think about our clinical experience, oftentimes we're mistaking case fatality for the reality, right? So case fatality is higher in men, right? They have fewer early stage cancers. They get fewer healthcare episodes. These small cancers are found less often. And this fools us into thinking that men have more aggressive cancer. And that's not really quite as true as we think it is. It's more nuanced than that. And just to go back, we find early stage thyroid cancers more often in women. The sex differences in the rates of other thyroid cancer types are much less notable, right? So 2 centimeter or less papillary thyroid cancers, 4 times more often in women than men. Anaplastic thyroid cancer, almost a 1 to 1 ratio. Medullary and follicular, a little bit higher in women than in men. This might be related to biology. It's also related somewhat to our clinician heuristics. And so to the extent that we can have a role in that, that's something that I want us to be able to think about clearly. So let's go back to our 2 cases and think about what happened to them and what the implications are for them. So we have Miss L. She was the woman who had the car accident and then had a workup for her neck muscle tightness and had this small cancer found. I was not able to convince her to do active surveillance. She had a total thyroidectomy. Her pathology showed a 0.5 centimeter papillary thyroid cancer. It was a T1N0M0 stage 1. Her 20-year survival is 99%. She has a MESA score of 3.99. And I just saw her back for the same symptoms that prompted her initial workup a few years ago. So she's still having neck tightness and discomfort and pain, and we have not actually solved her problem. Miss H, my other patient who presented with similar symptoms, but actually turned out to have a fairly aggressive cancer with metastatic spread and extracapsular invasion and involvement of the cricopharyngeus. Her voice recovered, which we were all very grateful for. Her nerve recovered. We did a completion thyroidectomy actually on her this winter. She has a papillary thyroid cancer that's a T4N1B. She's a stage 3. Her 20-year survival is 56%. Her MESA score is 7. You might remember she had many other competing illnesses. And in fact, actually, she has since had a readmission for her congestive heart failure. And so we'll be needing to balance her radioactive iodine treatment against the need to manage her cardiac care and prioritize her cardiac care over her cancer treatment as much as we can and are able to balance the 2. So I'm going to stop there and we can maybe take some questions.
Well, first of all, thank you for a very, very insightful presentation. And I think it gives us a lot of things to think about. I don't know, Dr. Erkin, do you have any questions to open the discussion?
I'll let you start off. I've got a few, but I'm going to let you open the platform here.
Of course. So you spoke about, again, the numbers are are incredible. They are eye-opening. The mortality rate that you were mentioning is just impressive when we compare it to any type of cancer. I mean, the number you give, 15,000 in 10 million versus 1.4 in 10 million, that's a huge difference. And then how as things get a little bit more aggressive, how it starts to equalize how we are treated or how we seek care. I mean, male and female. Do you think, as it seems like the way that we use healthcare is a big impact factor, or a factor that twists the number the way that we see them presented here? And the past couple of years, the COVID-19 pandemic, it changed the way that we use the healthcare system. Do you ponder that with us not using it as much or not being able to use it as much? Did that change in any way? Do you have any insight of how that changed? Or did men use it more the same that women did because we were only seeing the aggressive cases? Do you have any sense of what happened during these past couple of difficult years?
Yeah, we're actually just starting to look at that data now. I don't have any hard and fast answers now, but it will be really interesting to see whether the triage guidelines were applied equally to men and women, because that will tell us a little bit about how the incidence rates change. I think, I came at this from the standpoint of like, we're over-diagnosing women, but I think there's also this flip side of missing potential opportunities in men. You certainly don't want to subject men to overdetection of thyroid cancer, but you also want to make sure that we're not catching things later than we need to. It reminds me a little bit actually of the campaigns that we have now to increase awareness of cardiovascular disease in women, right? Because women's MIs get missed because we think about it more in men than women. And I think we could benefit from that a little bit in thyroid cancer. The mortality rates are still similar between men and women. So there's probably not a ton that we need to do, but I do wonder if we might give people some better quality of life and longer survival times if we did a little bit better job in men, even as we try to tone things down in women.
Right. Also, you mentioned 70% of people that have a thyroidectomy don't have any symptoms, and that sounds just about right. When you think about the patients that you see in the office, most of them are treated because they were incidentally found with a thyroid nodule, or you name it. Do you feel like, looking at the numbers and seeing how male patients apparently seek for care when their things are more advanced or aggressive, do you feel that male patients that are treated with thyroidectomy, likewise, are they asymptomatic when they seek treatment?
It's interesting. We actually didn't look by sex, which we should have done in that study to see like how the proportions fell of like screening physical exams versus radiologic serendipity by sex. We know from the healthcare practices just that women seek care more often, so they have more opportunities. But I don't know how that translates exactly into the pathways by which people come to their detection. That'd be interesting to look at.
Louise, if I could, Camilla, if you don't mind, do you have any sense on whether the trends that you report here with respect to gender disparities or in detection, and also with respect to utilization of healthcare, how that compares internationally?
That's a good question. I don't know what the data are in other countries about utilization by sex. That would be really interesting to look at. But we were just talking about how rates of access to, for instance, thyroid ultrasound differ by country. And in England, it used to be incredibly difficult to get referred for a thyroid ultrasound. And actually their mortality rates from thyroid cancer were a lot higher than other developed countries that had similar healthcare systems. And when they actually loosened up access a little bit so that people could get ultrasounds more, their mortality rate dropped, right? So there's something about needing to balance the right amount of access to imaging studies and to referral pathways so that you optimize the rate of detection to get the mortality rate as low as we can get it to go, right? There's some cancers that are just never going to be curable, right? But we might be able to bend the trajectory. And there are some cancers that will catch and cure regardless of how early or late we catch them. There's such that range. So the more that we can get down to what is the lowest mortality rate that we can achieve as a population, like that's, I feel like the holy grail.
Right. Just out of curiosity, do you know if the training of during residency of folks going through OBGYN, whether there is an emphasis on palpation of the neck? It's obviously out of field, but certainly that's one area where women enter the healthcare system on a regular basis. And in my own experience, it seems like almost surprisingly, they are the ones who detect palpable nodules more often in women. And so is there an emphasis? Do you have any idea in their training?
Well, I mean, of course, thyroid health has a big impact on pregnancy outcomes. And so I think the OBGYNs are trained to do a thyroid exam as part of that, like well woman, well pregnancy, general care. They also do labs, but they definitely feel people's thyroids because they're looking for nodules and enlarged thyroids. And I suppose you could make an argument that maybe they should just check labs, right? Like you basically don't want to miss subclinical hypo or hyperthyroidism, neither of which you would necessarily feel in the neck. I mean, you might if you feel a Graves gland.
Right.
But yeah, I mean, my understanding is that it's part of the training of well woman care.
And
so we would need to change those assumptions, I guess. We would need to, but yeah, I don't know how much we want to move that needle.
Yeah, sure. I unfortunately there is no equivalent in men. Men don't seek routine urologic care until kind of later in life when they may experience a problem. So I'm not sure that there is an equivalent. You also have experience in a really controlled healthcare setting. I think it's more controlled in the VA system.
Yeah.
Is there anything that where in that population, and certainly I don't know what the statistics are with respect to gender. Do you know what the male to female ratio is in the VA system?
Yeah, I mean, it's 95% male. So so those
Okay.
those two cases of women I presented are like one of a handful of women in my practice.
Okay, all righty.
It's 95, yeah, so the Veterans Administration is 95% male. And as a closed healthcare system, we do, the patterns of thyroid cancer detection and thyroid nodule detection have historically been different. They have definitely increased over the past 10 years or so. I would say, at the beginning of my career, I've been there since 2005. Thyroid nodule detection and thyroidectomy was much less a part of the landscape of our surgical care at our facility. And now it's more than half of what I do. And so there have been changes in reporting, especially the incidental reporting, because veterans are on average a sicker population than the general United States population. So they have many more imaging studies. So I think there's been a change in reporting. And then, with guidelines comes a compelling reason to do a biopsy or make a recommendation about follow-up. So double-edged sword.
Okay, but there is no screening program built into the VA system that might inform, us about, what the appropriate level of screening should be?
No, just like the USPSTF task force saying you shouldn't screen, do mass screening of the US population, they don't do it in the VA, and there are not any military exposures that have been associated specifically with thyroid dysfunction. So they don't do routine screening for it. Yeah.
Great.
Dr. Again, we have a question coming from the audience. There's a question regarding the difference in incidence between men and women. And they asked, the main difference in the incidence is at ages 40 to 60. However, the incidence of patients becomes quite similar at 70 to 80. The autopsies were performed probably in people who died of old age. So maybe the lack of difference at autopsies is also true for life patients diagnosed with cancer at that age. It could be that younger age is a true gender difference also at autopsies. I'm not sure I get the question.
Yeah, so I think the question is, are most of the autopsies in older people? And the autopsies were in a variety of ages of people. I'd have to go back to look at the data, but they were not solely in old people. They were, many were like traumatic deaths of young people, right? So our incidence rates certainly do seem to even out in older age groups. Thyroid cancer is one of the only cancers where it's more common in people in their 40s to 60s than it is later. It's a very unusual pattern. That's not a typical way that solid cancers behave. And I think that lends itself to this question of detection rates. But certainly since anaplastic, right, for example, tends to present in older people, and it is also closer to a 1-to-1 ratio in men to women. In that respect, I think the questioner is correct, right? So.
Right. As you were speaking, you mentioned the term radiologic serendipity, and it kind of hit a nerve right there. And I would wonder, okay, so we find it incidentally. How do we stop the diagnostic or therapeutic cascade after that? Or is there a way that you propose we should actually surveil people who really are going to behave aggressive? Because I think that's the overarching question though in thyroid cancer we have. Like when do we stop overtreating? Where do we stop overusing the healthcare system, specifically when it is a gray area, specifically in the male gender? No.
Well, you must have been a planted question, because we've actually been working for a few years to develop a clinical trial where we would actually monitor nodules as a first course of treatment instead of biopsying them. And this was actually, so we had originally proposed a trial to monitor cancers compared to immediate intervention, doing active surveillance, right? And then our radiologist partners, they said, no, you need to go upstream. You need to go up to the point where we identify the nodules. And as I've gotten much more involved during the COVID pandemic, thinking about cancer screening practices and the impact, and learned about other cancer screening practices, I understand now why that is and why they propose that, right? Because that's what we do for lung cancer screening. We don't biopsy every nodule, right? We actually get repeated imaging over time, and we look to see whether things grow, and then we biopsy them. We only biopsy right away the things that are like clearly cancerous. And if we could test that approach in thyroid nodules, we might find a tremendous benefit in terms of being able to pick out the cancers that are actually growing and changing and would benefit from early removal from those that are actually not currently doing anything. So we'll see. We're trying to see if we can get that funded, but we'll have to see whether the NCI thinks that's an important question or not.
Louise, this old adages die hard and take a long time to change. What do you think is how long do you think it will take for the popular wisdom and dogma that related to these two issues, related to the incidence and the aggressiveness, How long, what's it gonna take to get that, to correct that notion?
I think really what has to happen is we have to be lecturing the medical students on this concept, right? Because it's the people who are the young people who are coming along at the earliest stage in their career who are in the position to learn differently and to think about things in a new way. So it's great that I gave the talk here, but really probably I should be giving it to the residents and medical students. And so hopefully some of them will see this.
Right. And just out of curiosity, how, first of all, I have one question. As usual, when I listen to you talk, you have a term that I have never heard before, and that's medical heuristics. So can you please define that? Unfortunately, I tried to mouse over that term, and that function is Camilo blocked that. So what is medical? I apologize, and everybody's going to be saying, how come he doesn't know that? But what does medical heuristics actually refer to?
So heuristics is a concept in decision making, and that I am not an expert in decision making, but it's basically this idea that we use mental shortcuts to know what to do in a particular situation. And so we have these heuristics that guide us. So, and one of those is, thyroid cancer is more common in women than men. Another one is, heart disease is more common in men than women. Another one is, anxiety is kind of a woman thing, right? There are these, I mean, I'm saying them in sort of a pejorative way, and many of them are actually quite useful, but they can be problematic if they lead us down a pathway where we actually make a decision about what we think we're seeing prematurely. So like one example, like we can make mistakes in diagnoses by what they call premature closure, where you too soon close off the other possibilities of what a diagnosis might be, because you've used your sort of mental shortcuts and the patterns that we know from clinical practice of what's likely to be the cause of the problem. And we use that to decide what to do instead of saying, okay, well, it could be that, but remember, it could also be X, Y, and Z. So heuristics are really helpful because they help us move quickly and efficiently through the world, but then they can also trip us up if they lead us to go down a pathway too soon and miss a diagnosis or miss an opportunity for something. Does that help?
Yeah, very much so. Thank you. And I'm getting all kinds of text messages from people saying, why have I declared my stupidity here in an open forum? So I'm going to retract. I knew the answer, but I just wanted you to have an opportunity to show how intelligent you are. But
there may be other people on the call who could tell us a little bit more about it. I don't claim to be an expert, but I know that it definitely impacts our practice.
Well, I'm going to probably use that term 5 or 6 times today, just to throw it into my conversation. But thank you, Camila.
Yeah, I think I thank you for that. I also have to. We'll edit this part out of the session, but I also have to claim that I did not understand that term, and it's very interesting. You presented a couple of systematic reviews, and thinking about that medical heuristics is kind of. Those things that we have like hardwired into our brain, we kind of think about them like this happens when this happens, and when we do systematic review, we kind of keep that going because we're repeating or we are replicating or we are doing appraisal of the literature, and we're kind of giving people the outcome of those combined, and we go back, we kind of might tend to do that in difference with other types of research. So I was thinking, well, Dr. Aiken was asking, and you were saying. It's gonna take some time to build new literature and build a new way of thinking to break this dogma that we feel the gender difference in not only thyroid cancer, a bunch of other things, but thyroid cancer particularly. So that is maybe embedded into the guidelines of care, or I don't know. It's very interesting.
Yeah, I mean, I think we actually, as we create new guidelines, we should actually create some consideration of the sex of the patient and the tendency to over or under identify in the sexes and to raise awareness of it, right? To not fall into that trap on both sides.
So Louise, let me get to the $1 million question. With inflation, it's probably $2 million question. How is this understanding going to impact clinical care? I doubt that this is going to drive healthcare utilization by men to detect, I suspect not, to detect nodules and early stage thyroid cancers. I mean, I think that initiative is, as you alluded to, carries with it the problem of early detection and an overdiagnosis. Do you think, I mean, I doubt that it really enters into the equation when a nodule is detected as to whether to biopsy it or not in a male. I think that's an independent decision-making process once identified by ultrasound. So how do you think this is going to affect the big picture here in terms of actual clinical care?
I guess what I'm really hoping is that by raising awareness that of this, just drawing people's attention to the subclinical prevalence of the small cancers, and that we're detecting them so often in women, that it will maybe start people down that pathway towards understanding how active surveillance might be okay of identified cancers. You know, there's still such a reluctance on the part of many people in our field to monitor these small cancers rather than just get them out. You know, the anxiety of the clinician is as much something that we need to work on as the anxiety of the patients. So that's really my hope, is that maybe this will actually help with things like active surveillance. Because I think you're right. It's very hard when you think about the biopsy and like, should you just not biopsy women? That doesn't really seem right either, right? But I think if it can be useful to help people think about the different ways that we end up seeing people, and if we can get more people to understand that a cancer may or may not be active, that would be a big win.
Okay, interesting. Camilo, I've got to go find some way that I can use heuristics in my next encounter here today. So I have finished my questions, but I want to thank Dr. Davies for really spectacular, as always, really spectacular presentation, and thank you for all the research that you've done to really enlighten our specialty and all people involved in thyroid care.
Thank you for having me.
Same, I want to echo and thank you for an eye-opening presentation, and thank you for being here again. We hope to call upon you sometime soon. I would also like to invite all of the audience to register for the World Congress of Thyroid Cancer coming up in London in a couple of weeks, and to join in next week. Next Friday, we're going to have yet another rock star in the field, Dr. Hamer, speaking about understanding the role of patient and the physician in thyroid cancer care. We hope to see you all soon and hope you're all safe.